Right. Thank you very much. So this is an interesting talk actually, and was initially thinking of speaking about optimizing outcomes in ABOi. Then I think I get a message that let's look at high MELD. I said fine. So I will take you to this very interesting, for those youngsters, the young fellows and all, you may be interested to know that the first ABOi liver transplant, which was held in this country, was way back in 2013. And this was, one of the paper cuttings in Times of India. A very exciting thing that it was done first time. It was in Medanta, Soin, and I was there actually. And this was quite a big, event that we were doing ABOi at the time. And I happened to be actually involved as a hepatologist. So that was very, very initial learning days, and it was constantly in my mind whether this is going to work out in our country or not. Is it the right thing, or we should do something else? From that, now I'm going to speak on ABOi in patients with high MELD. So therefore, it's a huge sea change from the initial starting point where we started. And today we are looking at patients who are sick, MELD which is high, perhaps more than 30, 35, and trying to do a transplant for them. This would include patients who have got ACLF, who are sick in ICU and are having multiple problems. So we are going to face a lot of problems: immunological barriers, infectious problems, hemodynamic fragility, biliary vascular complications. This is a hugely important concern of limited time for desensitization and outcomes which may not be as good. So if you look at these points one by one, those who are sick, well, there are immunological barriers. There may be high preformed titers, and in this situation, well, it's not proven that those who are sick have high titers, but if you have a high titer and a patient who's very sick, this is a bad combination. And if you're not able to do a desensitization in these patients, then their tolerance to any complication in the post-transplant period may not be as good. There would be more endothelial injury, more chance of biliary as well as vascular complications. Sepsis will be a concomitant part. We know cirrhotic patients, ACLF, are already immune compromised. They have immune dysfunction. And when we desensitize them, if we try to desensitize them with plasmapheresis, rituximab and all, they'll be further compromised and more prone to infections. So sepsis would be the most important concern for us at all times. There would be a lot of hemodynamic and organ dysfunction problems, renal dysfunction, hyponatremia, circulatory collapse, coagulopathy, and the added insult of any AMR would be poorly tolerated by these patients, and certainly a combination of severe coagulopathy in the presence of plasmapheresis and sepsis would exacerbate the entire concern. I have seen that perhaps these patients who are sick and septic are having ABOi, they have higher vascular issues. I've seen it, I just think that they might be having high risk of vascular thrombosis, HAT. We have to be very careful. And also, once the problem happens, if it's a clean surgery, everything is fine, you're okay. But something happens, then I realize that their chances of, recovery from that insult is actually very poor. And this, I think, I'll talk about the standard protocol of desensitization, and then we will see, can we do a rapid desensitization in these patients? Is it worth doing it? Because we have a very, short duration of, window at in some patients. And we generally say that the outcomes of ABOi incompatible and incompatible. If the patients are good and stable, you are doing in an elective way, you may have comparable outcome. Although I personally feel that still the outcomes in ABOi incompatible are lower than what we get in the compatible transplants. But certainly those who are sick with high MELD, who have got a lot of other complications, septic state and all, in them I think there is a chance that you might be ending up with poorer outcomes, and majority of centers are very much hesitant in taking these very sick patients. I particularly am very, although we have done a lot of ABOi transplants, believe me, in ACLF and all, I still tell Subhash Mr. that we should not be doing ABOi in ACLF. We are not so good in that status. ACLF 3 and all is completely, I think, no for ABOi at this stage. Well, we all do such cases. I'm not telling that we don't do. We have done, these sicker patients, and you may be, lucky to, have a good outcome at certain stage. But the overall thing is that sicker patients like this are very challenging. Now, when we are managing them, we have these early post-op issues, immunosuppression, antifungals, antibiotics. They're always standard, and a concern for graft dysfunction, AMR. Now, my interest in ABOi actually grew more and more in the COVID times, and then I wrote this, review article in JCH. What are we doing in ABOi in compatible liver transplant in our own country? I took help from the IGABA to actually learn a lot of these things from him, right, when I was meeting about almost 2 decades back. With that interest, we saw that the early concerns, we all would agree, whoever is doing ABOi intravenous transplants, we know that sepsis, SFS, vascular thrombosis, bile leak strictures, AMR, and rejection per se, they are the concerns which determine the outcome of a ABOi incompatible liver transplant. I mean, a lot of intra-op issues are there. I think this is okay. Most of us would accept that in such a patient, ABOi incompatible, one would like to have a graft volume which is good, something which is more than 0.8, more than 1, and try and have minimal surgical complications, MHE thrombosis, as little as surgical complications as we have. Again, one thing I've seen that those patients who have, post-operatively in the early part, day 2, day 3, have got some MHE thrombosis, some hematomas, bile leaks. Invariably, they are not able to tolerate the hit in an ABOi incompatible as compared to a compatible transplant. So, clean surgery in a sick patient is acceptable, and you can have a good outcome. We look at all these, on day 1 and, standard practice, we all would know that. Only thing I would highlight is that I practice doing a titer twice daily for the first, 2 weeks, definitely for the first week. And doubling of titer is a significant entity in my understanding, and I will not wait for LFTs to change. Even if titers are increasing, I would take action on them. And a daily Doppler is absolutely essential. We must have to do it. Now, the standard protocol still remains standard. We will not change it even if it's a sicker patient, except in some situations where we bypass that. We'll come to that subsequently. The standard protocol, I'm sure somebody is going to speak on this, the desensitization protocols is a talk later on, but we all agree that we give rituximab in day -14 and try and institute the plasmapheresis if the titers are more than 1:16, 32 or 34. Our aim is to bring it less than 1:16 as far as possible. Some centers would start tacrolimus or MMF before the transplant per se, but we don't follow that. And steroids would taper over the next 3 months. So this is a standard protocol. So what we did was we did a survey, a national survey of practice of ABOi incompatible transplants, LDLT, in our country. This was in 2023, just very recently. Couple of things I found from this very short but interesting survey. Most centers would not do ABOi for high risk ACLF, ALF during this survey when I conducted this. Most of the centers would consider giving rituximab at least 2 weeks, which is the red one, prior to the elective date of surgery. Some would do 1 week, but certainly the longer the duration, the better it is. And the titer was the crucial question. Most centers would like to have a titer less than 1:16 when they're doing the transplant. So this is the practice in India. So now, if you are doing a high MELD patient, sick patient, ACLF, you cannot have this opportunity. You cannot have the opportunity of giving rituximab 2 weeks prior to that. You may not have the option of, having the ideal titer. So we need to define what is a sick patient and then, go accordingly. But certainly, there would be some exceptions. I'll come to an algorithm later on in the later part of the talk. And we need to understand in the post-operative status, AMR versus sepsis, a very close call. We may not be able to sometimes pick it up carefully, but we should be very careful. Any patient who's having rise in titers, rise in LFTs, falling platelets, and persistent graft dysfunction, you have ruled out vascular, everything, biliary, then it is a situation for AMR to be there. There is some, evidence that those who receive a lower dose of rituximab may have higher AMR, but I'm aware that some centers, I think probably have to talk to Mr. Srinivas Reddy. I think you were using a lower dose of rituximab, but those things we can discuss subsequently. And also that the pre-transplant titers, do they impact the AMR post-transplant? Well, as for this study from Professor Igawa, yes, in the pre-op phase, the IgG may not bother much, but yes, of course, if you're having an AMR, then your titers would certainly rise majorly, and you have to be careful about that. And then, of course, some strategies to handle this AMR, which I think is a very standard. I'll skip this slide. And okay. Now, I come to this study which is actually published from China. A very elegant study, but I'm not sure how much is it replicable in our setup. They had sicker patients, ALF patients, 101 ALF retrospective data analysis, compared 66 compatible versus 35 incompatible, and they had a quadruple immunosuppression regimen. Very interesting. Basiliximab, steroids, tacrolimus, and MMF, and they would give IVIG from day 0 to day 10, and rituximab on the day of transplant, a single dose 375. Interestingly, this was a protocol, so all patients will receive IVIG day 1 to day 10, and what they found was the pre-LT antibody titer did not matter. They did at a higher titer of 1:192 actually, which decreased by less than 1:16 on day 1 itself, and they could actually show that a single dose of rituximab has its impact up to 3 months, which is true fact that it really has an impact for 3 to 4 months. And the survival of these patients between those incompatible and compatible was almost similar, 86 and 83%. I don't think anybody else would have repeated or replicated such a data, and in our setup we have seen many times. I know a couple of my colleagues have done ABOi in ALF also. I was talking to Dr. Anand, I think he has also done, but we don't think that ABOi incompatible is something which we can do in our practice as of now in ALF patients. So the standard protocol would determine 2 weeks before transplant a rituximab dose, 40 to 70 hours prior to transplant. We would like to do the plasmapheresis to reduce the ABO titers to less than 1:16 as far as possible. Sometimes I would take 1:32, but yes, ideally is 1:16 or less. And on day of transplant, we give IV intravenous methylprednisolone bolus in the anapathetic phase, and standard post-op concerns for infection, immunosuppression and all. Now, those who are sicker patients, just try and developing an algorithm for these patients. Somebody like a sick patient, more than 30 MELD, which is quite common in our ICU these days. In fact, it is more common to see sicker patients than the stable patients who come to us for liver transplant. So in the first step, we would try to identify, can they have a donor which is compatible? Well, if they don't have one, then we need to look at their titers carefully. Low titer, things are okay, favorable, whereas the high titer, which is 1:64, then we are in trouble, and we have to see, can this patient tolerate a desensitization with rituximab or plasmapheresis or IVIG? So somebody who's septic, sick, culture positive, hemodynamically unstable, I don't think we can use these modalities, but a stable patient in a selected one, perhaps we can do. So if we can do and we have time, which is an ideal, but if we don't have the time and we have to proceed, then we have to take it for an urgent, or at a very high risk case, and then do a case by case, selection of these patients, and then try and see if we can have an outcome which is optimal in these very sick patients with high MELD. So to conclude, high MELD, especially ACLF, which I think pose significant challenges, and these patients are, as of now, especially ACLF3 and all, are not the ideal candidates for ABO incompatible liver transplants. Graft dysfunction is very, very critical part of the entire thing, and we have to differentiate between AMR and sepsis with very good judgment, and a rising antibody titer post-transplant is sufficient reason to actually do an action, maybe plasmapheresis or whatever you want to do is your practice. ALF, again I say, perhaps is not suitable for ABO incompatible at this stage, and we need to have a collaborative experience. We had done survey earlier 2 years back, and I think it was very, very useful, but I think that we can actually, as part of our societies, do a collaborative survey across all the centers in North and South, have a common registry, and try and see what our experience is, which I think would be very productive. Thank you very much.
Yeah, thanks. It is open to the house first. Yeah, please.
Yeah, thank you, sir, and a nice talk. Charles here. Hi. Doing AB incompatible for ACLF patients, do you think there's any advantage of using a hemoabsorption column to a TPI? Does it reduce the risk of infections in such patients?
You're not clear actually, a lot of echo. Tell again. Okay, the type of plasmapheresis. Okay, yeah, if I am getting your question. So I've seen that the standard plasmapheresis which we do is reasonably good enough. But if in some situations we are not able to get the titers down, then we do the immune adsorption actually, where we have seen, interestingly we have seen that some patients are not responding to the standard TPE, and when you do the immune adsorption, actually you can actually achieve that. So I think there is a significant role, but I don't use it as first line. There was an abstract presented on this from our Max team in one of the recent ILTs. There is no difference in fact. Only thing which was different was that some patients who were not responding to the standard exchange TPE did actually respond to the immune absorption, and we could take them for transplant. I don't think there was a risk of infection which was different. I don't think so. This is again very interesting. Upfront, no, I don't think I have an experience. No, but also I think that upfront nobody would have used it. For AMR which is not responding, and you have used plasmapheresis and you have IVIG, there bortezomib has a role because it is a plasma cell, attacks on plasma cells. And I know my colleagues in hematology, in myeloma and all, they use it a lot. So bortezomib is an excellent drug, but I have not used it personally.
Hi. You were very negative about ALF, but not so negative about ACLF. But don't you think ACLF are probably patients who are at worse situation for sepsis than ALF, who are actually in a good physical state until they became unwell? And you showed that study where they give it on the day, rituximab on the day of the transplant. But that may be so for hyperacute patients. There are many ALF which don't need a transplant. You wait for 72 hours, 2-3 days or 4 days. You might get time for 2-3 days to give rituximab. I think you've done that, haven't you? The reason you feel more comfortable for ACLF generally, I think, is because you think you can get away waiting for a week. But in that week, they could get septic, and therefore you preemptively do the transplant, even though you can't wait for that 2 weeks. Sometimes you can't wait for the 1 week. So personally, I would think ALF is probably even more suitable than ACLF. I don't know what you feel.
I think very, very, right comments, Professor. I totally, get the sentiment you're telling. But in real life, what I have seen is that if an ALF is there, who's needing a transplant, and sick in ICU, we still have that mental, block that we need to have some time frame to.
I think it is a mental block.
Yeah, I'm telling. So that needs
Truly,
a level.
I don't rush to do a transplant even in ALF until unless they've grade 3-4 encephalopathy.
So,
a lot of the ALFs actually don't fall into that category.
Right.
There is time to think about it.
So I think that, like in one of the previous meetings, I remember one of my colleagues, surgeons from here, somebody who was telling that in ALF they did 3 patients upfront without any no rituximab, nothing. Straightway they did ABOi incompatible and patients survived. So it is very difficult to have a message from that, and to do ALF, well, it is very challenging. And as I agree with you that this is a block. We want to really have some time, and doing somebody if an ALF is there and the titer is 1:256 or 512, I would be very hesitant doing a upfront transplant in ABOi incompatible. ACLF, right? I actually said that ACLF 3 and above are very bad candidates. They are the worst actually. You are totally right. They have more sepsis, more infections. But yes, psychologically you have some time to think. You have some 1 or 2 weeks which you can buy. And if you're lucky, patients have improved on your medical measures, you may be there. So between the two, yes, I cannot say as of now, but I don't know, we need more experience on ALF definitely. I don't have that experience on ALF.
Just one comment.
Yeah.
So like what Dr. Ella said, at least in our experience, what we've seen is patient with ALF, whatever ABO incompatible we've done, we've given rituximab, usually at the time of surgery or immediately after surgery. And for one patient, we've done a splenectomy also. Patients with ALF actually do very well with ABO incompatible, at least in our limited, it's a small experience, it's just some 6 or 7 patients. It's the patients with ACLF which struggle because they've already been sick for a long time, they're very depleted, and then they drag on, and we really need to manage these patients very carefully post-op. In fact, we did a multi-center study through ILD-LT. So we divided them into ALF and ACLF group. The outcome for ABO incompatible ACLF was around 50 to 60%. The outcome for ABOi incompatible ALF was more than 90%. Of course, there are probably more children in the ALF category from Japan. But
children is also, Dr. Rela, an important point because they have a much better profile for ABOi compared to adults.
I think to some extent ALF patients are more better preserved, they can tolerate the little bit of insults, and the risk of infection is lesser also. And we're not giving a lot of time between rituximab and transplant, so they get a new liver which is working, so they can tolerate this stuff. Whereas the ACLF patient, they're sicker before. I think maybe that's something that we can think of. In fact, sometimes I think even ACLF patients, no point in giving 1 week, 10 days, just the day before transplant, give the rituximab, and we've not done that. But, because when you see ALF patients do so well, I have that. In fact, we are discussing one patient who underwent an emergency ABO incompatible for PNF today in this session. So again, we can discuss that in that after that case. Thank you.
Okay. Thank you. We'll go.